All right, guys, welcome. This is the second expert session. Thanks for joining us. We're going to discuss today low body weight policies and procedures. I'm Kelly Rossi, and I'll play the role of moderator and panelist. Currently, I'm the Associate Director of Sports Nutrition at the University of Virginia, and I work with 11 sports teams here. Before that, I was with the Office of Naval Research as a contractor for 6 years, supporting research in the Department of Human Performance Training and Education with Marines. I'd like to introduce our other panelists, Lauren Link and Victoria Lambert. Lauren Link is the Director of Sports Nutrition for Purdue University. She specifically works with football, men's basketball, volleyball, and soccer. She also co-instructs the Sports Nutrition Education course, which provides the sports nutrition program with education or with undergraduate volunteers. She recently published her first book, also called From Athlete to Normal Human. Victoria Lambert served as Princeton University sports dietitian for its 38 teams and 1,200 Division I varsity athletes from 2009 to 2016. She was also the nutrition therapist for the university's outpatient eating disorders treatment team, which has a reputation for being one of the best college treatment programs in the country. Currently, her focus is on working with clients privately and using her passion and education to promote a healthier environment for people on the planet. Thanks to both of you guys for providing your expertise today. I'd also like to welcome and thank our partners at the National Dairy Council for supporting us for this expert session. I'd like to introduce Allison Parker, who's the Director of Nutrition Science and Partnerships. Welcome, Allison.
Thanks, Kelly. National Dairy Council is excited about the opportunity to sponsor this expert session as part of our ongoing partnership with CPSDA. And for those of you who might not be familiar with who we are, what we do, National Dairy Council was founded in 1915, and it's a nonprofit organization funded by 43,000 dairy farmer families across the United States. Our diverse team of scientists, RDs, and communications professionals work with colleagues in academia, government, and the industry to develop and fund research. Once the science is published, we translate and package it up for a variety of stakeholders, including scientists, health professionals, and the general public. And in addition to our work with CPSDA on the national level, National Dairy Council also has a large network of state and regional dairy councils across the U.S. who do a lot of work at the local level to support sports RDs in their regions. If you're interested in getting connected with your local dairy council or learning more about opportunities for collaboration, please feel free to reach out to me directly or through Amy Friel, and we can help make that connection. So I'll now kick it back to Kelly so we can begin this great discussion.
Thanks, Allison. So first, a few logistics before we start. All of your phone and computer lines are muted, and they'll remain muted for the duration of the call. So if you have a question, just submit in the question tab as part of the control panel on your screen. Usually it's on the right of your screen. I'll moderate the questions and ask them to our panelists as the conversation flows. I may also just answer your questions by typing a response as well. And we'll try to open it up for questions toward the end if we have time. But if not, you can always email any of us with remaining questions as well. So please note that we'll follow the policy main points handout that you received in your email this morning. That'll be the first part of our discussion. And we'll begin with Lauren and Victoria and myself sharing our insights on what our policies look like and how they're developed, and then open for questions, like I said, at the end. So first, like I said, we'll talk about each school and just give a little description. And basically, you're getting a snapshot of 3 different schools and 3 different institutions and conferences: an ACC school, an Ivy League school, and a Big Ten school. Each of these places does things differently, and every other school will do something differently as well. So hopefully this will give you a nice snapshot to get you started and continue to learn as you go through. Victoria will first provide us with an overview of Princeton.
So when I arrived at Princeton, I was lucky to walk into an athletic medicine department that already had started a lot of really good work on writing their policy, and so that had been in place since the early 2000s. One of its really strongest points was that it used a really strong rationale and gave a great background for the policy. It included a thorough screening program for every athlete and team that we were lucky enough to conduct in-house for doing our own annual pre-pars. And some teams received in-depth assessments. We had several weight class teams when I was there. It included a risk stratification and treatment recommendations that was coordinated in conjunction with our eating disorders team. And that team included an athletic trainer and myself serving as both the sports RD and the eating disorders team RD. It also included weight as a medical indice and outlined confidentiality, as well as who could and could not obtain weights for athletes and under what circumstances. And then again, specific practices and protocols were laid out for weight class sports. We had sprint football, wrestling, lightweight crew.
At Purdue, some highlights of our policy. We try to really clearly state the appropriate practices for collecting and sharing body weight and body composition measurements. We use a yearly nutrition screen to identify potential disordered eating, as well as a triannual Dexa scan that we use as a screening tool to identify low body weight and low body fat percent. We use clinical diagnostics to identify those potential eating disorders as well. And we use a quantitative classification for those levels of care that we have identified as green, yellow, and red. And then lastly, we include a flow chart of our treatment team care plan.
Yeah, and at UVA, our policy's really only been in effect truly for about 2 years more formally, and we actually still don't have it really written down as a policy in our books. Our administration wanted to keep it as a guideline more than a policy so that we have the flexibility to really adjust things as we go and tweak things. So we technically call it a guideline, but it's basically the same as a policy. It's just not formalized there. And we identify student athletes through their physicals, their first year, and health history questionnaires for all returning student athletes. We have a medical hold and provisional status if a student athlete's health is determined to be at risk and participation in sport isn't advised. And we clearly outline our quantitative risk strategy, risk classification guidelines of low, moderate, and high risk. And if we decide that someone is high risk, we have a contract or an MOU that will develop for that student athlete on a treatment plan for them to be able to know what they're doing.
So all of the things we just highlighted are on that policy main points handout that you guys received this morning, I believe. Also on the handout is a table of the similarities and differences between the schools. And as Kelly mentioned, every school is different, so this is just a snapshot from the ACC, Big Ten, and Ivy League settings. And the handout also touches on common pitfalls and difficulties that we've run into, some of which we'll touch on later today.
Yeah, so we'll really start now with a discussion of how we've gone about developing our policies at each of our institutions and important points we think that would be helpful for you guys to consider. So first, you'd want to think about who will be on your team and who's allowed to see the data and information that you're collecting. All three of the schools here use a sports medicine doctor, a sports psychologist, a sports dietitian, and an athletic trainer. At UVA, the information is shared among those four people. The strength coach is not involved unless it's a team bod pod that's not really having to do with a low weight policy, and even then it's generally more that we're looking at trends with them. We found here that the strength coaches tend to handle the data properly, but that's something that we reassess anytime there's someone new coming in and make sure they really understand how to handle that.
Similar to Kelly at UVA, at Purdue, only a HIPAA-covered staff member, which would be our sports medicine staff, so the athletic trainer, doctor, and dietitian can see the raw data, like the exact body fat percent, pounds of lean mass, pounds of fat mass. We personally group strength staff into the same group as coaches, so sport coaches, when it comes to viewing the body composition results. They can see trends, averages, outliers, but they can't see raw data like that body fat percent number. And this is actually a fairly recent change for us, probably about a year ago. We made this change. Coaches and strength staff used to be able to see all the information that we had, and as expected, that change has not been a big hit amongst some coaching staff. So it's involved a lot of education on the reasoning behind our change, as well as working with each staff to try to provide information that's pertinent to them. So feeling out, okay, what are you looking for in the data? How can we help you within the constraints of our policy? And for us, the reason for that change is we personally felt like we had coaches, and even some strength coaches maybe, who abused the data or used it against athletes pointing out specific body fat numbers that they felt like that athlete or the whole team should be at. So we felt like it was time for us to pull back that data and make that change, but it has not been easy. Definitely involves a lot of education and sticking by your message when it comes to a change like that.
And Lauren, are you willing to share what body fat percent cutoff you use for the Dexa?
For us, we start to look, we start to at least raise a red flag around 18 or less, which is obviously higher than our 12 to 15% cutoff that we talk a lot about in terms of women, at least for body fat percent. For us, we do that because the Dexa tends to read higher, and we use the 3 to 5% higher on average. I know, I'm sure people out there are using different percent errors. We use 3 to 5%, so with that in mind, 18 could be, 15 or less on a different measure. So if we see that 18 or less, we'll start at least looking, okay, are there other factors involved? And if it gets much less than 15, I think we have always found that that's been a problem, that there's other factors involved with that.
So I'll just keep it brief and concur with everything that's already been said. Our team included MD, AD, RD, psychology. We didn't have a sports psychologist at Princeton, but we did have licensed psychologists who were beginning to specialize in sports psychology. And in terms of our strength coaches, we treated them the same, but as I started to build the program, we were really able to provide them with a tremendous amount of education about privacy, prevention, early intervention, and it really influenced the way that they were behaving and obtaining weights in the strength facilities, which led to a lot of really positive changes. For those of you who are the first dietitian at your institution, you may have an opportunity to really establish that policy from the get-go like I did. Nobody was doing body composition before I got there, so it was a little bit easier. We didn't have to take something away from coaches or strength coaches, so keep that in mind.
Yeah, and someone asked about if anyone of us is using body comp to help measure performance. I'd say at UVA, it's more, I try to remind the athlete that this is one data point if we're doing BOD-POD and we're talking about it. I mean, I've had athletes that come in and, they're at that minimum of 12 or 13%, and then they may, come back and they'll be 15% and they're actually performing better at that higher body fat. So I use it as an education tool, but not necessarily to measure performance per se, but more to kind of educate them on, it takes some time to figure out where your body performs best.
Exactly. It's not about, it's not about doing it it's about doing it in the reverse, helping them identify where they perform best as an individual, not setting a random target without having good information about the rest of their well-being or performance.
I would add too that I mentioned the reason for our pulling back on that information was because of abusing body fat percentages and some of those numbers. But another reason for me is I found that we were spending a lot of time sitting around with coaches and strength coaches hashing out a 2-pound muscle gain or a 2-pound fat gain in regards to performance, and trying to educate them on they could jump on the Dexa scan tomorrow and see that go back down. It's such a small change, and there's some percent error involved. So I think it can be used for performance, but you have to be careful in getting into that because it's a slippery slope, in my opinion. And so I think if you're going to use it for performance, focusing on the trends that you see and comparing them maybe to the same time last year can be helpful.
Yeah, and we've our policy here we've developed is to not share the actual numbers with the athletes either. It's something that we go back and forth on, but we've had athletes that took the number and just used it the wrong way, and they'd compare with their teammates. We still get a lot of kickback on that, and if there's times where we feel like the person really would benefit from knowing the number, like I had an athlete who was in the ROTC and they were telling her she was too heavy, and I gave her the number because it helped them see that she wasn't. Someone else asked if we have a percent body fat cutoff that we use to not allow athletes to participate. That's kind of why, and we'll get into this in a minute, that's kind of why we don't use body fat percent only, because I felt that, you know, because that number can sometimes be inaccurate. Like Lauren said, you know, there's that 3 to 5% difference with Dexa, for instance. So we generally just kind of look at it, but we don't necessarily use that as the only tool or data point. So next we're going to talk about screening and identification. So an important aspect of developing a policy is determining how you'll screen and clear the athletes, both incoming freshmen and returners.
We added our screen at Purdue about 2 years ago, and we had talked about it a lot. I think it's a great practice to have in terms of screening athletes for low body weight and disordered eating. But it's important to remember as you're implementing one that you're really thorough about how you go about that. And one of our big holdups with going live with our screen was that the question of will we have enough staff available to handle however many athletes trigger on our screen. For us, our big concern was sports psychology, which we have in-house, but you know, not as much maybe as we would like, or that we need. So just be careful, you know, if your policy states that any athlete who triggers on your screen has to meet with a sports RD, a psychologist, whatever it might be, and you don't have the resources to handle that number of athletes who trigger, you now created a liability by identifying a problem but not actually handling it and not following the policy that you just implemented. So I think Victoria will hit on this a little bit too. This doesn't mean you should ignore the problem, but if you can't handle it in-house, maybe look to refer out, but think about how that might work for your program.
Yeah, and talk through with the medical team how it'll work when someone is identified in terms of how they should be following up with nutrition in sports, like what their goal is and the set amount of weight that you may need them to gain weekly, when they'll be cleared, how long they'll be monitored. We didn't have all this in place at first with our policy, and it did cause some confusion with coaches and athletes, which is understandable. So really take the time to make sure everything is worked out properly and really think through it before you implement it, even if it happens right at the beginning of the year. So for us, it was like we had worked on it all summer, and then, you know, the team didn't get back together, but it ended up getting implemented because the docs saw some athletes that needed to be flagged, and that didn't go over perfectly as you would expect. And here at UVA, we use that health history questionnaire for returners as well to look at weight changes and history of bone injuries or any new injuries, menstrual status and menstrual status changes, and preoccupation with weight, and all of those things would help with us flagging them and getting them to nutrition.
Right, same for us. So the screening program has been in place well over 10 years at Princeton, now maybe closer to 15. And as I mentioned previously, we did our in-house pre-PARs that include a health history, and I'm going to contend that if you're collecting data on a health history form, you're screening. And so it's a common tactic, I think, for programs and departments to not want to look, and then they don't have to do anything about it. But that's just not how it works in medicine. If the data is there and you see a problem and it's documented on, you're responsible for it. With that said, how detailed you want to get with, you know, referring to your in-house staff, that's a process every department and program has to determine. And like Lauren and Kelly said, walk through your process and create a step-by-step flow chart and put it in place and see how it's going to go. And you definitely can contemplate doing a QI study or conducting a pilot study. You can look at your data retroactively and see how many athletes would have had a positive trigger, and look at that data before you go down this rabbit hole, if you will. Just a note to keep in mind too, there is a distinction between someone with a doctorate in sports psychology versus a licensed psychologist who can practice and do psychotherapy and who may have a proficiency in sports psychology. So if you have a strictly performance-based sports psychologist, you may need to refer off campus for psychological care regardless. So make that distinction in your program as well.
Yeah, and someone asked if we can share our numbers for a male athlete. So if I were to be using just body fat percentage, it would be somewhere between 3 and 5% for us with BOD-POD. But again, like I said, we don't use that. We really focus more on BMI, but Lauren might have something else to add.
In terms of a cutoff for Dexa, I would probably say 6 to 7 or less would be at least a red flag. I will say in my 4 or so years here, I have not seen under 8 personally, and we obviously are doing a lot of scans, so I haven't run into that yet, even with seeing some disordered eating in male athletes, but I haven't run into that really low body fat percent on our Dexa.
Awesome. Thanks. So next is the assessment plan. So after you identify, you need to decide who will assess and obtain the measurements. So is it the doctor? Is it the dietitian? Is it the athletic trainer? At UVA, the doctor or athletic trainer does the initial measurements and physicals. We don't usually sit in on those. I know at other schools, some dietitians will go and sit in on those first year physicals, and it's a good place to really, identify some athletes. But generally, because we have those questions in our questionnaires and physical questionnaires, the athletic trainer can flag those for us and send them our way. The dietitian here usually does the follow-up measurements. We'll do periodic weight checks for sports only if it's during preseason and used for hydration assessment, or if there's an individual circumstance with the sport. There were a few that were doing it before I arrived, and that's something that we're working on getting changed currently, actually. Wrestling's an exception, and generally our football team does get weighed each week by the sports dietitian, but we try to stress that the coaches that this isn't a standard, and the data is really only shared with the athletic trainer, and I believe with the strength coach as well for football. But I think that's just the trend for the strength coach that he gets.
I would add, when it comes to strength and conditioning and that sports performance staff, it's important to decide their role in your program. In my experience, they're frequently involved in weighing, or at least interested in doing so, and they're usually the most interested party in body composition results. So at Purdue, we allow sports performance to take body weights, but we really stress that they should be at predetermined intervals and planned ahead of time. So whether that's once a month or once a week, we're similar boat for football, for instance, and wrestling, but not just having the athlete spontaneously jump on the scale and not more often than you originally determined you would for that team.
I would just concur with all of that, and especially with what Lauren said about predetermined intervals, so athletes are aware. And just how you conduct it too. We were able to get our strength coaches to start collecting data in a blind way, and then they would just look at trends or changes over time as well, particularly with football and summer camp, which our sports med team felt was perfectly appropriate in terms of monitoring day-to-day recovery in an intense situation like camp, or just looking at hydration status. It does have a utility, and so I think it's important to educate about that utility, and using weight as a vital is equally important as keeping the information sensitive and private.
So next, how will you conduct the assessments? Will it be through BMI or body fat or both? So we kind of already got to this, but like I mentioned, we use BMI and other indicators, not just BMI, not just body fat. We do assess BOD using BOD-POD. We assess body fat, but it's not all the time. And really, when we do that, use those, we also are looking at, like I said, the other individual risk factors. So injury, menstrual cycle, and those types of things, history of disordered eating.
Yeah, for us, since we are consistently doing those 3 DEXA scans each year and at predetermined intervals for each sport, we rely pretty heavily on the body fat percentages from those scans. If someone's been flagged, then we would definitely start monitoring their weight, which would also factor in to following that individual. But just like Kelly said, I think it's important to take other factors into consideration. It can't just be one measurement that is determining how we treat that athlete. So making sure we're looking at the individual's history and those different factors that may be at play.
Yeah, absolutely. At Princeton, I I completely owned and implemented the body composition policy, so I was the only provider doing body compositions, and it made it very easy for me to control that information and the flow of that information. Athletes identified at risk during screening might only be identified based on weight, menstrual history, history of stress fractures, and a body composition assessment may or may not even be conducted. It's really individualized. If I was going to use it as a part of the physical assessment, or I felt like it was necessary, I would add it. And we might use a multitude of factors, including BMI. Most of you know I'm a big proponent of ISAC, and so I would do a complete somatotype profile on my athletes, which, by the way, also helped with eating disorders recovery for some athletes who could really see where that weight and that tissue was going. So it really depends on your institution, what resources you have, what equipment you have. And I will also just add that some sport RDs don't believe athletes should ever be weighed or have their body composition evaluated. So, talk to your peers and colleagues and figure out for yourself how you feel about that. But again, no matter what you decide, monitoring changes and trends over time is the best practice.
Yeah, and as Victoria's alluding to, and like we've said, as you can see, it's all different everywhere. So some places may not agree with doing any body comp assessment, which is a great point. So determining the frequency of follow-up is another really important thing to provide in your policy and work through. At UVA, it tends to be every week or every other week, depending on the risk category that they're in and if they're pulled or deemed on medical hold. But we really do try to approach each athlete individually, as Victoria mentioned as well, and base it on what's going on with them at the moment. If they're more at risk based on genetics or a sport, sport-focused weight concerns, we may not feel they need as often of monitoring. We try to be flexible with their schedule as well. So, to a certain extent, if they have a big race coming up, is it something we'd want to pull them before or after? That's something we had some trouble with in years past that we really try to think about, because this really is their identity as well. So is it going to be too risky to let them run the race or not? So that's something you want to think about too.
For us, follow-up, when an athlete's first identified to be at risk, we try to make sure we're following up weekly. And if they're making progress, then we'll typically start to space that out to first every other week, then maybe every month. But just like we've hit on a lot, making sure it's individualized is important. And I can say there's no predetermined timeline for when you will space that out. I have athletes who've moved on to seeing me monthly or once a semester pretty quick. And I have an athlete who I've met with just about every week for the last 3 years, and probably will for her last year. So it's a total variation in what you might see with follow-up.
Yeah, it was exactly the same for us. And as someone progresses in their recovery, whether that's an eating disorder or something unintentional, it's individualized and it will decrease over time, however it is you start. I will just say that, for athletes who screened positive for any trigger, we would generally give them 4 weeks to demonstrate that they could start to recover. And if after 4 weeks they couldn't demonstrate that with some simple education and guidance, then it was probably an indication that something else was going on. And if you let that 4 weeks get away from you, everyone knows how quickly a semester can fly by. So, we would generate a list of everyone we were following in the first month of school and pretty well stay on it. And if you don't do that, you really miss an opportunity for early intervention. And someone to linger for maybe what could be a whole academic year.
Yeah, that's a great point. So when we're talking about someone that's going to be pulled or reduced from participation, developing a contract or a MOU, Memorandum of Understanding, is really beneficial and important. And we've alluded to that before. And all three of us use these when reducing participation for an athlete. It really helps to give them and the providers a clear picture of what's expected and how they can work toward improving their health to allow them to return to play. Because without that clear guideline, it can be really overwhelming and cause a lot of anxiety for a lot of them, since, like I said, it is their identity. Each MOU here at UVA is worded differently based on the athlete, but that's something that, you know, just depends on where we think they need to be and by when, and what we think we should be seeing. And making sure that the medical team, again, is all on the same page as to what necessitates pulling an athlete or putting them on hold or reducing participation, and discussing how they'll stay on the same page and who that go-to person is for monitoring is really important. Again, it's, like I said, something that we've really had some issues with, so it's worth me repeating a few times. So really just making sure that that contract helps delineate everything. So also, you know, when they'll meet with the sports psych and how often for that too is really important, and for how long.
Yeah, the contract is huge for us, and I think a really important piece is that you have it up front right away. If you have a concern about an athlete, looking into that contract and making that contract, and the entire treatment team, should be on board with that. So the athlete, the treatment team, their coach should all be aware of and on board with the contract from the beginning. And that contract should outline the circumstances that would warrant pulling them from activity, so you're really clear about that. The more quantitative, the better. So what consistent weight will the athlete be pulled from activity? And I can't stress the importance of the consistent weight, because you don't want them to manipulate their weight. So determine whether that's a weight range or maybe over, you know, an average over a few weeks, whatever it might be, but really focusing on a quantitative measure. And I would keep in mind too, when pulling an athlete from activity, it doesn't necessarily mean pulling them 100%. It might be at first reducing their mileage or their number of practices a day or week. So that's something to consider.
Yeah, I would completely agree with both Kelly and Lauren. Being consistent and quantitative is essential. For athletes who we were concerned about eating disorders or weight manipulation, we also added USG assessments. And, you know, weights could be biweekly, weekly. And you just have to be really careful that if you have your psychologist and your MD has diagnosed someone with an eating disorder, I would just caution that you're not bordering on treatment without really calling it treatment. So that's another consideration for making referrals and making clear diagnoses. As far as limiting participation, we really subscribe to the school of Ron Thompson of activity, and as much as was medically appropriate, we would preserve that athlete's sport participation. And again, that should just be individualized, but I think for the reasons everyone mentioned in terms of their identity, their connection to their team, for some athletes, it's supportive, you know, and for others, clearly it isn't. And you know, each team has to decide that. Each care team has to decide that with their athlete. And then I will just also say that, you know, as a medical indice, confidentiality was something we protected with a vengeance at Princeton. And if that athlete did not want their coach to know or be involved, that was completely respected, and the physicians would find a way to communicate with that coach so that they could, you know, at least understand that it was something private and personal, and that we would, you know, communicate with them as much as we possibly could, but always aligning ourselves with what the athlete needed first.
Yeah, and being consistent really helps as well. Like, we've had a few athletes on the same team, and we've had one athlete come in and question, like, why am I being held and someone else isn't? And not that we share the why with those people, but, you know, at least we have it in their contract. They have that reasoning. So, you know, they're looking for any reason to not have to be, you know, reduced in activity. And someone's asking about, on the one hand, you're saying don't share weights, but on the other hand, with the contract, you're elevating the use of consistent weight. And yeah, that's kind of a tough thing. I mean, weight is one of the easier indicators for to use that we can measure consistently each week. But we're also trying to look at other things as well. And that's why, you know, assessing other data points is important as well. Victoria, did you have something to add?
Yeah, let's just make sure we keep the distinction clear between screening and identification. and now we've moved into treatment, so, or monitoring, if you will. And those are two very different things, and you're going to treat the weight very differently in both of those scenarios.
Great point.
I think it's fair to say that the coach doesn't necessarily need to know those weights. You know, you can still be confidential as long as the coach is aware that we've determined as a treatment team this weight that we're going to pull from. You may have some coaches that are not comfortable with not knowing, but I think there is a way to preserve the confidentiality still around that weight.
Yeah, and generally when we have a contract, we don't, even though the coach is signing it, our contracts don't say the actual weight. It might just be it's always, you know, what we want them to gain per week, and the coach isn't even necessarily notified of that unless they're asking. Then I may say, yeah, they're meeting their goals, or, you know, I'm not giving them any specifics there.
Yeah, our coaches were not involved in contracts or invited to sign contracts unless an athlete specifically invited their coach to participate in their treatment and had a supportive and affirming relationship with that person. Yeah, they were not involved in that at all.
So two different schools there, and I think why we include the coach was because we were holding the athlete was, I guess, our reasoning, but definitely some different opinions there, which is awesome. Good to have. That's what makes the world go around, right?
I think speaking of coaches, another important aspect of these policies is communication with coaches and your support staff around body shape and body composition. Purdue, we have an acceptable verbiage handout that you guys were emailed this morning. And we found this to be a relatable way for the coaches to see what is and is not appropriate to say to an athlete. And a lot of those terms on that paper were direct quotes from a coach that we would add as they came up. So we include this handout with the materials that we provide to every new coach on our staff. We've also brought it up to, you know, a tenured coaching staff if they need reminded. I think it can be a good topic, whether you're using a handout like that or not, but just a good topic to have at maybe a coach's development day, or if you have any kind of beginning of the year coaches meeting or similar event. It's a really good topic to hit on, because sometimes they mean well, but they don't know how to address it. They don't realize that they're doing something wrong.
Yes, so really educating them up front is super important. And really, like, if you have an ability to let them have some input where appropriate, that could be great. And not to say input on the athlete's weight, but for instance, we realized that getting our first-year athletes in for physicals a lot sooner would be really helpful for those coaches, so that their first-year athletes aren't pulled the day before practice, because that did happen in the past. And then that poor athlete is, you know, prevented from bonding with their team, for instance. They're not getting their training in, which isn't as much of an issue as more of the mental piece of it. And the coach is losing that athlete for the beginning. Whereas, you know, now we've kind of tried to work with the coaches and help them be more proactive about it and get their athletes in sooner. If it's a fall sport, try to get them in, you know, maybe in June or July, and then they have time to work toward that goal before practice starts and before the coach really wants to have them be active and participate.
Yeah, oh, go ahead, Laura. I completely concur. It's really important to align yourself with the coaches and help them feel heard, instead of it being a punitive relationship. I mean, we all understand the loss for an athlete and a coach to have limitations on participation. And I think over time you'll have experiences where you make a really great intervention and that coach sees that athlete come back healthier and stronger and perform, and eventually they will start to trust you that you're out to actually help them and their athletes. But that does take time, and those encounters don't happen very often, so you do have to celebrate them. I will say that we did offer biannual in-services around body weight and body composition, and the years that I was there conducting them, they were really well attended, and it was a great opportunity to educate them on the sports science and the treatment approaches. And so the more you can do that, the better. And don't forget, you are the expert on this content.
And I think an important piece of the buy-in with coaches and that trust that you just mentioned, just having support from administration is really big. We've probably all worked with coaches who are great around body composition and weights and things like that, and coaches who aren't. So especially, regarding policy changes or implementing a new policy, if you're in that boat, for us, we changed that policy. It was a pretty major change, and to have the administration support was essential, because if the coaches are unhappy, they're going to the administration. They're going to the AD or their sport administrator and voicing that concern. So it's important that they back up your decision. And I think that coaches really need to understand that as a treatment team, we have the athlete's best interest in mind, and that they need to respect that sports medicine team's decision regarding the health of the athlete, just like they would trust them if it was a torn ACL or a broken bone or something of that nature.
Yeah, so also continuing to emphasize athlete safety and welfare as our reasoning for this policy is really important, because that's truly why we're doing it. It's not because, we just feel like making extra work for ourselves and really making people's lives miserable. And we definitely, remind them of the policy coming from administration as well. It's really, important that we can say that, because that's obviously the person they report to, and they can go to them and question it if there's an issue. And a lot of times there's coaches that feel like you're targeting their sport because it's a known, weight class, low weight sport. And so reminding them also that it's a department-wide policy can be really important too. We've had, one coach that really did say, like, I feel like my athletes are the only ones that are getting pulled. So also just making sure that that isn't the only team that you're pulling athletes from. Not that you should go to other sports and pull athletes, but is there one team that you're looking at more closely, just because that's where most of the athletes come from? Make sure you are checking in and your team is checking in on that as well, and they're not, ignoring a male sport just because it's a male sport, and, stereotypically there's less risk of eating disorders in that sport, or less weight issues in there. Someone asked about do you verbally provide the athlete with the actual weight they should be at, or just weight goals per week, even if you don't put the actual weight on the contract? For us, it kind of depends, after assessing the athlete, I would determine that based on what I think the athlete could handle. So generally, if they have disordered eating pathology, we would tend to go more toward a blind weigh-in and just talk about the weight goals per week. But if it's someone that, seems to not have any disordered eating pathology, but, they still are having struggles with gaining enough weight, then that might be someone that I might share it with. Do you guys have anything to add on that?
I would say the same. I've done both. I think if you do try to weight, kind of like you mentioned, Kelly, just recognizing what's maybe realistic at that point. Especially if there's disordered eating involved, you wouldn't want to start with a big a big weight gain. So if they're at 110 and you want them to eventually be at 125, okay, but maybe you start with 115 as your goal and kind of work up to make it manageable. But yeah, I've done both blind weigh-ins and setting a weight goal with them.
I'm just going to say, I think it really depends on what the student's diagnosis is. If they are diagnosed with an actual eating disorder and you're working on transitioning them to some type of higher level of care, whether their participation is reduced or not, you're talking about weight with that patient. And if you're doing blind weights, to me that indicates a different level of care. And so I think you just have to approach that on a very individual basis.
Great, thanks.
We talked a lot about polling.
I'm sorry.
Go ahead.
I'm sorry, you guys. I'm sorry. Can I just add one more thing? Yeah. I also just want to say, just in response to, everybody approaches setting those weight goals different, and again, if you are dealing with someone who has a diagnosed eating disorder, as opposed to someone who just has disordered eating or body image issues, I would advise against setting interim weights, because it's like pulling the rug out from under them. Okay, well, you made it here, but actually you need to make it here. And if you set those interim weights, we found year after year after year, that is where the athlete would want to stop. And so you have to tell them what full recovery looks like if you're dealing with an eating disorder athlete.
Yeah, that's a good point. I was just going to say, we've talked a lot about polling athletes, but an important piece to consider too when you're making this policy and setting a contract with an athlete is return to play standards. So just like pulling an athlete from activity, the quantitative measures regarding this are really important. So what consistent weight will activity be reintroduced, and being really clear on what that activity will be, how often, how long will they be able to do it. So being really specific and setting those guidelines from the beginning as well.
Yeah, I'm not forgetting that return to participation isn't just about weight. So we looked at everything in our assessments, as does Lauren and Kelly, but we would also include, what was going on in terms of concern in the community or from their teammates. How's their academic performance? What's their medical status? How's their psychological and emotional well-being? Are they prepared to return? Can they handle the stress? And some of you may have had encounters with athletes where they are really, and this is more rare, but I experienced this many times, where an athlete was really trying to make a decision about leaving their sport. And sometimes having the medical support to do that was an opportunity for them to make a change in their life, graciously and with some help. And so that's also something to contemplate and pay attention to if that ever happens to you. I will just say that, clinical experience and best practices out there, since there is a limited amount of research and evidence on this, is that return to play should be highly individualized. And obviously you're catching a theme here from the whole presentation. And it's, when you're writing policies, using the words may and individual is very helpful in that context. And that language does give you flexibility in designing individual programs.
Great. And yeah, with our policy, we took our standards. We, used some of the points from the Red S and modified after a year of implementation. But again, consistency and ensuring the policy states where they need to be and how long, and just really, being clear about that is really important. Someone wanted us to clarify who is included on our performance team. So for us, like I mentioned, it's the doctor, the athletic trainer, the sports psychologist, and the sports dietitian, and those are the people that meet as a team to discuss the athlete if there's a problem or an issue.
Same for us. Same for individuals.
Same.
And with us, our sports psychologists are very careful with what they share. So this past year, we have some different staff, and they're super strict about their confidentiality. So we have all athletes sign this confidentiality HIPAA type waiver in the beginning that says that anyone on the medical team can discuss their health, but then the sports psychologists actually have them sign something separate once they're meeting with them that basically says they won't discuss their information with anyone unless they sign a specific contract that says you can discuss this and only this with the sports dietitian only. Like, it's super, super specific. So we've kind of struggled recently with not even knowing, they're not sometimes even allowed to share with us who they're meeting with. And that's just become like a recent recent struggle for us, we understand where they're coming from on their end too, because they're needing to protect the trust that they've developed with that athlete. But that's become a little struggle for us, and that just made me think of that. So.
Yeah, that's a great point, Kelly, and that language is all around releases of information. And it is really important to understand another provider's training and philosophy in terms of what matters to them, and confidentiality is incredibly important to therapists and psychologists. And so having your athletes sign releases of information or requesting them is a good standard of practice. And then once they do, then the psychologist will be happy to talk to you, but not until they sign that release.
Yeah, and I usually will try to ask the athlete if they're meeting with sports psychology and see if they'll share that with me. And then it's just an easy, then I know, and nothing has to be signed, and, I don't have to ask the sports psychologist. They don't have to tell me no. Someone else asked, how much access does strength staff have to medical information? Our strength staff is included on our individual performance teams. Ours doesn't have access unless they ask and it's deemed appropriate, like for an injury or something. But I think that would be something they have to go through the athletic trainer for.
I would agree. In the case of an injury, where they're talking to the doctor or the athletic trainer would be the really only release of medical information for us.
And is there anyone who doesn't do body comp at all, or does it only in specific circumstances? What are thoughts on not doing it at all? Like I mentioned, we tend to not do it for the low weight. We usually tend to do more of just the scale and using the BMI, but every so often we will use the bod pod. Lauren had said she uses the Dexa because she's doing regular scans with them. But again, we've all kind of mentioned it's very individual. So lessons learned, what have we learned from being a part of this policy development at our institutions? For me, it's really taking into account that the effect that has on the reducing of participation has on an athlete and their ability to bond with their team, like I said. So, that first-year athlete that gets pulled right at the beginning of their season. Differentiating whether there's a true case for disordered eating pathology or if it's truly just a genetic or sport-induced weight loss. And that's where the sports psychologist really can play a big role here as well, if they're obviously allowed to discuss that with you or, talk in generalities. Ensuring that the entire medical team is on the same page before implementing is really important, as I've mentioned, and coaching buy-in going much more smoothly if they're provided with some education and somehow figuring out a way to make them feel like they've contributed to the policy.
Yeah, I would completely agree with all of that. And then I'll just add that, that contract and having it in writing is as helpful for the care team as it is for the athlete, because as the dietitian, you will likely end up doing a lot of case management, and having it written is a great way to help keep everybody on the same page, athlete and team alike. And then I'll also just say that it's easy to get a little bit jaded, and on a very rare occasion, someone may have a low BMI but are actually healthy and very well appearing on that physical assessment. And so, it's important to keep that in mind, that genetic diversity does include that. And that's why it's important that you have no hard cutoffs, and why it's essential that you don't just use one parameter like weight. So build in a list of parameters and set up your evaluation like that, just like criteria for diagnoses.
For me, a couple things. I know we keep mentioning the contract. So important to have. It's kind of a relief to be able to rely on that, to fall back on it. And I think having it like right away, if you're concerned with an athlete, I'd rather have it and not end up really needing it, or maybe it was overkill, than not having it up front and then having to add it. In my experience, it can be kind of awkward then to be like, okay, well, let's now add a contract, or let's start weigh-ins, even though we haven't talked about that yet. So it kind of takes out that awkwardness for you, and it's just a really easy thing to rely on and fall back on. And then just remembering that a lot of times you as the dietitian might be the voice for the athlete. You know, the coach sometimes is really just focused on performance and the fact that they've lost their star athlete maybe. So you often are the voice of reason for that athlete. As we know, a lot of times they're isolating themselves from teammates and friends, so they may not have those voices in the picture. Parents sometimes are the problem, or at least part of the problem. So again, my experience has just been, as busy as we all know that, just trying to remember that sometimes you really need to stand up for that athlete. I've had to check somebody in to an inpatient facility because their parents didn't think they needed to go. So they felt just, you know, totally isolated and alone. So sometimes that might have to be you as the dietitian in that role.
And Victoria, someone's asking about ISAC and if you're the only one certified, and or is there value in having strength and conditioning training staff having it?
Oh, that's a tough question. While I was there, I was the only one certified, and right the year before I left, I was finally able to get one other athletic trainer certified, and she was the AT for wrestling. And I mean, that's probably a longer conversation. I love the idea of having athletic trainers certified. I'm not so sure I love the idea of having strength coaches certified. I think it depends on, again, you can't tell someone what certifications they can get or not, and the education is phenomenal. So I think it just depends on what your policy would be around who's going to actually conduct that testing.
And someone asked how many of these cases we have per year. For us here, it's probably a few that might get pulled fully, completely, and then about 10 or so that are being monitored, you know, on a regular basis. So not a ton, but again, I think it sometimes, you know, there's always the possibility of people being missed as well.
Yeah, I would say similar numbers for us, probably a couple at the most who might be severe enough to be pulled, and then hopefully 10 or less that we're following pretty consistently. Important to remember too that and we are all pretty well aware of this, but it's not a quick process. Even if you have somebody who's, you know, been pulled and now they're back in, you might be monitoring that person all 4 years or 5 years that they're with you. It just totally depends.
Yeah, I would agree. I mean, we had 1,200 athletes, so I had more than that. I probably had a caseload of 20 or 30 per year that I was monitoring, but not all of those were limited in participation or getting really high levels of care. The other thing you have to remember is that even if your prevalence and your caseload is low, these athletes take up a tremendous amount of resources and time and energy. Mm-hmm. So you hear 5 or 10 and you're like, no, that's not that much. However,
yeah,
it represents
every week.
Yeah, it represents a high volume of work. So
yeah. So 30, that's a ton. Awesome. Well, that's about all we have time for today. If you guys have other questions that we didn't get to answer, I don't see any more on the screen, but if you think of anything else, feel free to, if you don't have our emails, feel free to contact Amy Friel and she'll direct them to us. And we're more than happy to answer things offline after this. But thanks so much for joining us today, and just wanted to thank the National Dairy Council again for their support of these awesome expert sessions. If any of you have suggestions or ideas on things you want to see in the next expert session, we may have a few topics that we already have decided on, but anytime you have ideas, please pass those along to us. We hope you've found it useful, and there will be a recording posted on our webinar library on sportsrd.org. Thanks so much, and have a great day.